Good day. I'm Imelda Williams. With this presentation, I'm going to give you feedback on the Formative Test 1. I trust that you have completed the test first before you view this feedback so that you can get as much as possible out of this feedback. The formative test 1 had two types of questions. The first is multiple choice questions with each 1 mark. And then the scenario-based questions, which has 3 marks, and that is very similar to what will be expected in the final exam. And with those scenario-based questions, there will be image manipulation software available as well. So question 1, the question was the radiographic appearance of mallet's finger deformity. And of course, the option there that's correct is the dorsal avulsion at the base of the distal phalanx. And that normally happens in sports when someone catches a ball and the finger is bent. So the next question was one of the identify a hallmark sign of rheumatoid arthritis. And the option there is osteoporosis. So some of the key hallmark signs of rheumatoid arthritis includes erosions as well as cartilage loss, which then in the end will lead to loss of joint space as well. So in the early stages, patients might have osteopenia, which in the end then will progress to osteoporosis. So the next one was about Hangman's fracture, and which is the correct option there. And the option there is a bilateral pedicle fractures of C2. And on the lateral view, you would also be able to see that there will be anterior displacement of C2 on C3. So this is just a straightforward answer here that the most common odontoid type fracture is type 2. So again, very straightforward one on this one. A Smith is a volar displaced distal radius fracture. If it's dorsal displaced, then we're thinking about a Colles fracture. And then the final one on the MCQs is about Kienbock's disease. And Kienbock's disease is a vascular necrosis of the lunate. Also, remember all the other types of avascular type diseases. So one that's very common, of course, is Perthes disease, which is of the femoral head. And then with Freiberg's disease, it's of the metatarsal heads. Colles disease affects the navicular. And then another one that's quite common is Osgood-Schlatt's disease, which affects the tibial tuberosity, which we commonly see on a lateral view of the knee. So the next cases are our scenario cases. And as I already mentioned, this is going to be very typical of what you can expect in the final exam. So for each of the scenario cases, they tend to be out of 3 marks, which means that you should write down at least 3 facts. So if we look at case 1, the clinical indications were a push injury to the right wrist. So on our DP view, we can see that if you look at the proximal row of the carpal bones, they look very disorganized. And we can also see here is a distal undisplaced radial styloid fracture, and then also a very pronounced scaphoid fat stripe. Then when we look at our other views, so that's the oblique view, which tells a little bit more, but it's the lateral that will actually show you the important indication here. So if we draw a line, then if you remember that your capitate on the lateral view, the capitate should align with the lunate and the lunate with the radius. But if we draw a line, we can see the lunate is still in contact with the radius, but the capitate has been displaced dorsally. And that means that this is a perilunate dislocation. So the overall comment then is that there's a perilunate dislocation of the right wrist with an undisplaced radial styloid fracture, and you could mention that there is a pronounced scaphoid stripe. And then for case 2, this was an injury to the right hand following a fist fight. So I think I'm just going to stay on this previous image. It's actually showing the pathology the best. So I'm going to zoom in a little here. So clearly we can see that there is a fracture of the neck of the 5th metacarpal, but when we look at the fracture, we can also see that it is comminuted and that the displacement is volar angulation, and this is very typical of what one would see with a Box's fracture. We can also see that there is some significant soft tissue swelling. So your overall comment would then be there's a comminuted fracture at the neck of the 5th metacarpal with volar angulation and significant soft tissue swelling. And then you could mention that there's also a Box's fracture. So for the next case, this is a wrist injury after fall from a monkey bars, and we can clearly see that this is a pediatric patient. So on the PA view, we can see that there is a sclerotic appearance at the level of the epiphyses. So we can see that's happening there, but nothing else that we can really pick up. And then on the lateral view, we can actually see that there is a slipped epiphyses. And this is of the radius, and this is in keeping with a Salter-Harris type 1 fracture. And there's also, of course, quite significant soft tissue swelling. So your overall comment would be that there is a slipped epiphysis of the radius, which is in keeping with a Salter-Harris type 1 fracture, and there's also significant soft tissue swelling. So the next case is also a pediatric case. So let's just zoom in here as well. So this is a patient who tripped and fell and has a swollen right wrist. So we can see that it looks like there's bumps on both sides, but which could be either green stick or torus fractures. But the lateral view is the one that would show you that this is a true green stick fracture, because we can see there's a break in the cortex of the radius while the opposite side is maintained. So there's an incomplete transverse fracture to the distal radius. There's no displacement, and it's in keeping with the distal radius green stick fracture. So case 5 was a workplace injury with a chainsaw. I think I'll just try and make it a little bit slightly lighter. Okay, and let's just zoom in. Okay, so what we can see, we can clearly see that there's two fractures of the third and fourth proximal phalanx of the right hand. But on the second proximal phalanx, we can also see that there is a fracture as well. And this fracture appears as if it's comminuted because we can see there's multiple loosened lines. However, that fracture is undisplaced. So if we look at the next case, then here we can see the undisplaced fracture of the second proximal phalanx, and it's mid shaft of that proximal phalanx. And then we can see that the fractures of the third and fourth proximal phalanx are angulated fractures. So they are also comminuted because we can see there's multiple loosened lines now that we have got this view. And then also that there is also significant soft tissue swelling. So your overall comment for this would be there's angulated, comminuted, complete fractures to the third and fourth proximal phalanx of the right hand. And there is a comminuted, undisplaced fracture to the second proximal phalanx, and there is significant soft tissue swelling as well. Okay, so case 6 is a diving injury, and the request is to exclude any C-spine fractures. So the key thing is, so when we count this 1, 2, 3, 4, 5, 6, 7, when we get to 7, we can see there's a significant drop in the vertebral body height on the anterior part. So that shows you that that is a compression fracture. The other important thing is that the posterior vertebral height is maintained, and that then excludes a burst fracture. So if we zoom in here, we'll be able to see that this fracture also is comminuted. So your overall comment on this is that there is a comminuted compression fracture of C7 in the anterior vertebral body height, and also because the posterior vertebral body height is maintained, it excludes a burst fracture. So case 7 was a motor vehicle accident that happened at 40 k's per hour. The airbag deployed, and now there's some tenderness over the cervical spine, and they were querying whether there is a fracture. So if we look on the open mouth view, we can see that the lateral masses align quite well. There is nothing there that indicates that there could possibly be a fracture. And when we look at the lateral view, we of course want to check for any disruptions in alignment. So the anterior vertebral body lines are maintained. The posterior lines are maintained as well. And the vertebral body heights are also maintained. So there's no significant drop in any vertebral body heights. And then when we look at the AP view, we can see the available cervical vertebra that we see. There's no significant injuries there. So overall, this was a normal study. But should you get an example of a normal study in the final exam, you still need to write 3 comments. So first thing that you can write is that the alignment is normal because it has been maintained. There's no loss of vertebral body heights, and there's no indications of any fractures or dislocations or prevertebral soft tissue swelling, and that this is a normal study. So the final case is a patient who tripped and fell downstairs, bumping the head and landing awkwardly with severe neck pain. So On the open mouth view, the first thing that you would notice is on the right side, the lateral masses are overhanging, so they are not aligning. We can also see that there's an increased space from the odontoid to the lateral mass on the right side. And then when we look at the lateral view, we can see that there is a fracture of the posterior arc of C1. And all these appearances are in keeping with what's typically called a Jefferson's fracture. So overall, you could write that there is a C1 fracture with overhanging right lateral mass, and then also posterior arc fracture of C1. You could also mention the increased space between the peg and the lateral mass on the right side. And then in addition, you could add that is a Jefferson's fracture. Okay, so that is then the feedback on formative test 1. So as always, you can contact me if you've got any questions about this formative test. Thank you.